In this section, we will discuss the effector functions of adaptive immunity. In this section, we're going to cover effector functions of adaptive immunity. Remember that we said that the effector function of T helper cells is to make cytokines. We've also mentioned in other sections of the lecture that there are different types of T helper cells. For the boards, the ones that you need to know are T helper 1 and T helper 2 cells. And here's the process by which they're made. Any naive T cell, specifically a T helper cell that's leaving the bone marrow, leaves as what we call a Th0 cell. They haven't decided yet exactly what cytokines they're going to make, what types of cells they want to stimulate or activate. That decision comes when they're presented with their antigen. The cytokine milieu in which the T helper cells are stimulated will determine the type of T helper cell that it will become. That T helper cell, the type of T helper cell it becomes, will determine the type of cytokines that it makes. For example, let's look at Th1 cells. Th1 cells will develop, again, from naive Th0 cells. If they are stimulated by their proper antigen, proper specific antigen, within the environment of IL-1, IL-12, or interferon gamma, then they will be promoted to become Th1 cells. As Th1 cells, they will secrete cytokines such as interferon gamma and TNF-beta that promote cell-mediated immunity. They also will promote production of opsonizing antibodies. So you can kind of see the picture here of what's going on. If a T helper 0 cell becomes a Th1 cell, then by the cytokines that it secretes, it's going to promote activation of cytotoxic T lymphocytes, NK cells, and macrophages, a cell-mediated type of response. Because these cells also are known as the killer cells, and because they can secrete lytic enzymes into the environment, this is also known as a pro-inflammatory type of response. So Th1 cells stimulated by inflammatory cytokines like IL-1 and IL-12 will then stimulate other cells as part of cell-mediated immunity in a pro-inflammatory type of response, mediated through the cytokines that the Th1 cell is making, interferon gamma and TNF-beta. Now, if the Th0 cell gets stimulated within the context of something like IL-4, which is secreted by mast cells and eosinophils, then this promotes more of an anti-parasitic type of response. This will induce that Th0 cell to become a Th2 cell. As a Th2 cell, it will secrete cytokines such as IL-4, IL-5, IL-10, and IL-6. And these cytokines are known for their influence on eosinophils, also for their influence on B cells. IL-4, IL-5, IL-6 are all used by B cells to undergo class switching. These are the cytokines that tell a B cell to stop making IgM and start making one of the other secondary classes, IgG or IgA, for example. One of the interesting things that you'll note is that these two different types of cells, Th1 and Th2, will actually shut each other off. Therefore, if you have a Th0 that becomes a Th1 cell, the interferon gamma that it starts to make as a Th1 cell will inhibit any other cells from becoming Th2 cells. And vice versa, if it becomes a Th2 cell, then the IL-10 and IL-4 that it secretes will inhibit other cells from becoming a Th1 cell. Why is this important? Because again, with immunity, we're talking about specificity, specifically in the adaptive processes. We're talking about specificity, we're talking about the ability to handle the antigen that's there. So if the T cells know I've got, say, a virus, then it doesn't want to turn on all of its B cells or doesn't want to turn on its eosinophils and mast cells because those won't help with an antiviral response. Instead, it promotes a cell-mediated type of response. Vice versa if it's a parasite. If it's a parasite, you want your eosinophils on. You don't want your cytotoxic T cells on. They're not going to really help you. So in this aspect, the Th1s and Th2s can kind of direct the specific type of response that they want. So here's a question. A 64-year-old man complains of difficulty breathing and a productive cough. Physical examination yields a fever and blood-tinged sputum that reveals acid-fast bacilli upon staining. X-ray analysis reveals a lesion in the upper lobe of the left lung. A lung biopsy reveals a cystic lesion surrounded by a ring of lymphocytes and macrophages. Which of the following best characterizes this man's condition? A. Acute bacterial infection. B. Chronic bacterial infection. C. Fungal infection. D. Autoimmune disease. or E, neoplasm? The answer is B, chronic bacterial infection. You can see from this question that this is just screaming tuberculosis, right? We've got acid-fast bacilli, we've got a lesion in the upper left lung, we've got a cystic lesion that's surrounded by a ring of lymphocytes and macrophages, that's a granuloma. This is Mycobacterium tuberculosis, and this is chronic bacterial infection. How do you know it's chronic? Again, remember what we talked about previously. If you see lymphocytes and macrophages, that's chronic infection. Here's a table of the cytokines that are associated with Th1 type cells. These cytokines are interferon gamma, IL-2, IL-12, and IL-18. Notice the effects of each of these cytokines. Interferon gamma is important for upregulating HLA expression, activating macrophages and NK cells, and inhibiting Th2 cell production. So this again is involved in keeping that Th1 process going and not allowing the switch to Th2, or not allowing Th2 cells to become activated so that we can focus our attack. IL-2 is involved in activating all kinds of lymphocytes. It can activate T cells and B cells. It activates adaptive immunity, therefore, and cytokine production, and basically activates effector function in adaptive immunity. Now, IL-12 is made by the APCs. It's made by the macrophages. Remember that this one is what induces Th1 cells. It's what induces the Th0 to become Th1 type cells. It's also involved in CTL activation and NK cell activation. IL-18 is specific for NK cells. Comes from macrophages, specific for activating NK cells. The Th2 cytokines that are important to know are IL-4, IL-5, and IL-10. IL-4 is really important and involved in B cell switching to IgE. Remember, we said that these Th2 cytokines can be involved in class switching. Well, IL-4 is important in switching to IgE. IL-4 is also important in inhibiting Th1 activity. IL-5, remember, is really important in activating eosinophils. Also involved to some extent in B cell differentiation and class switching. And IL-10 is involved in alternative macrophage activation. It's sort of a suppressor cytokine known for its abilities to kind of downregulate inflammatory responses and downregulate cell-mediated responses. Remember also that it's involved in quieting the Th1 type response. So another question here. One of the drugs used to treat multiple sclerosis is glutarium or acetate. Its mechanism of action is thought to involve a switch in T cell response from a pro-inflammatory to an anti-inflammatory response. If this is true, which of the following cytokines would be expected to be found in the serum of a patient who has been taking this drug for several months? Is it A, IL-12, B, interferon gamma, C, IL-10, D, TNF-alpha, or E, IL-1? The answer is C, IL-10. Remember that we classified Th1 versus Th2. We talked about Th1 being a pro-inflammatory type of response. Therefore, if you use the Th2 cells, which turn off that response, you get kind of an anti-inflammatory effect. Since IL-10 is the only one of the options that's a Th2 cytokine, that's the correct response in this question. So let's talk a minute about superantigens. Superantigens are bacterial toxins that activate multiple clones of T cells in a non-pathogen specific manner, which leads to unproductive response. It causes massive T cell activation, release of large amounts of cytokines, and causes system toxicity. Toxins that are active for superantigens are active at very low concentrations. You don't need a lot of toxin to get this to take place. Some examples are Staph aureus toxic shock syndrome toxin and Strep pyogenes toxin A. So how does this happen? How does this T cell get activated in a non-specific manner? Let's look at this diagram. We have the T helper cell on the left and the APC on the right. And we can see our signal 1 coming through here. We see that class 2 MHC being associated with TCR and CD4 from the T helper cell. Now here we see the superantigen, and notice that the superantigen is binding to the outside of the binding area. It's not part of the peptide recognition. It's binding to the outside of the TCR and the outside of the class 2 MHC. And when it binds to the outside, it will pull those cells together and force them to interact and keep the interaction there. Remember we said that part of the role of the thymus was to eliminate any of the T cells that bind too strongly to MHC because they would overreact. Well, this is exactly what's happening with the superantigen. We have something that's forcing that T cell and that MHC class II together, and it will cause the T cell to overreact. And if that superantigen stays bound, which it tends to do, the T helper cell can't shut off. What do T helper cells do? Cytokines, cytokines, cytokines. This T helper cell keeps making cytokines, which then cause the inflammation, cause vasodilation, cause activation of cells, which then release lytic enzymes. Those types of things lead to the processes that we see in these superantigen type of responses. And what's the end result? Septic shock, right? We get vasodilation, we get hypotension, and we get septic shock, very classic for toxic shock syndrome, for example. But this is how it works. So the binding of a superantigen to the outside of the TCR and the outside of the MHC class II, forcing them together. Now, another effector function of the T cells has to do with peripheral tolerance. And there are a couple of mechanisms in which this can come about. One of them involves APCs, and it's APCs that present antigen without inducing co-stimulatory molecules. This induces a state called T cell anergy. In another process, we have inhibitory molecules present on T cells, such as the CTLA4, and we also have regulatory T cells that come in two forms, natural Tregs and induced Tregs. So here we have a diagram of T cell anergy. Remember we said that for a T cell to become activated, it has to have two signals, the signal through the MHC TCR and the co-stimulatory signal through CD28 and CD80. Well, if the CD28 and CD80 co-stimulatory signal is not present, then we have a different state of activation that takes place. What happens if this is the case is that the T helper cell becomes anergic, and what that means is that it gets shut off permanently. Now, why would you want to shut a T helper cell off permanently? Well, let's suppose that somehow it makes it through the thymus, but it's an autoreactive T cell. It's specific for an autoantigen. What can happen is the APC can present autoantigens through MHC class II, but it won't upregulate its CD80 to its cell surface. And what happens is that T helper cell that's specific for that autoantigen will come and recognize that autoantigen, and you get signal 1, but without the CD80 being expressed, you don't get signal 2. And in effect, the APC then is able to energize that T cell or shut off that autoreactive T cell so that you don't have an autoimmune response. Now, suppressor or regulatory T cells are a fairly new concept that has come out in immunology circles, and it's starting to creep its way onto the USMLE Step 1. So it's important that we cover these things and talk about the highlights or what's important. The regulatory T cells, or Tregs as they're known, come in two different flavors, natural Tregs and induced Tregs. The natural Tregs are hypothesized that they are an alternative outcome of strong TCR binding to self-peptide MHC complex during thymic education. Again, if we have a TCR that's binding tightly to MHC, what the normal process is that T cell gets eliminated in the thymus. That's negative selection, right? Well, there are some theories that state that perhaps some of these cells go through an alternate differentiation pathway and become regulatory T cells or suppressor T cells. Another theory is that these Tregs get induced as part of a normal immune response. When you have an antigen in the absence of inflammation, for example, perhaps one of these anergic type of reactions, instead of turning the T cell off, perhaps that T cell gets changed into a Treg cell. Now, these Treg cells, what they do is they secrete cytokines that are involved in down-regulating an immune response, cytokines such as IL-10, cytokines such as TGF-beta, which suppress an immune response, and hence the name regulatory or suppressor T cells. Another important association for these Tregs, if you see it on the boards, is FOXP3. FOXP3 is a transcription factor that we use to identify Tregs. So here we have a nice overview of the whole cell-mediated process, and we can see how Th1s and Th2s work to stimulate different effector cells. The Th1s over on the left, you see once they're stimulated to produce interferon gamma, then those types of cytokines, interferon gamma, IL-2, will go and evoke a cell-mediated response. They'll activate CTLs, they'll activate NK cells. Over on the right, we see a Th2 activation. With the Th2 activation, remember, you get IL-4, IL-5, IL-6, IL-10. You get B cell responses, and the B cells will make antibodies. Now, through either one of these mechanisms, you can get killing. With CTLs and with NK cells, it's more of a direct type killing. However, the B cells can also contribute to cytotoxicity of infected cells or altered cells through their antibodies in a process called ADCC, which we'll talk about in a moment. But first, let's focus in on the CTLs. How exactly do the CTLs kill? In this slide, we see the mechanism of CTL-mediated cytotoxicity. The first step, as with any T cell, is recognition of the specific antigen. Remember that we have the T cell receptor on the CTL, or the CD8 T cell, which will recognize peptide in the context of MHC class I, which is found on, for example, in this case, a virus-infected cell. That virus-infected cell is presenting viral peptide through its MHC class I. Remember that endogenous pathway that we discussed. Once the CTL recognizes that peptide, if it's the specific antigen for that CTL, it will rearrange its cytoplasm. And note that it moves all of its granules down to the side of the cell that's closest to that infected cell. Once it has these granules rearranged, it will then degranulate. It releases those granules into the environment, which will then cross and make their way over to the virally infected cell. Now, once the CTL dumps the granules into the environment, the CTL will dissociate and take off, because those granules are nonspecific, and they would just as soon punch a hole in the CTL as they would in the virally infected cell. So the CTL will dump its granules, and then it will take off. The granules, in the meantime, hold enzymes such as perforin and granzymes known to punch holes in cells. So they will punch holes in that viral cell and cause its destruction. Pretty straightforward and pretty elegant in the mechanism. So NK cell-mediated cytotoxicity is another way that cell-mediated immunity can destroy cells. With NK cells, remember that one of the things they go around looking for is the expression of MHC class I. There are actually two different types of signal receptors that you see in NK cells. Over here on the left, we have pattern recognition molecules and what we call KIR, or killing inhibitory receptors. Now, the pattern recognition molecules, those are specific for certain markers of viral infections that are typically found expressed on the surface of a virally infected cell, different types of viral peptides. If that pattern recognition molecule is stimulated by a marker of viral infection on the surface of that cell, it sends a positive killing signal to the NK cell. Now, the KIR is the one that's looking for the MHC class I. And note that it's not looking for any specific peptide, it's just looking for the presence of MHC class I. So if a cell is expressing MHC class I and the KIR can see it, then that sends a negative killing signal to the NK cell, or in other words, it tells the NK signal not to kill. And if both of the receptors are stimulated, both the pattern recognition molecule and the KIR is dominant. It's a dominant negative signal. So as long as that KIR is seeing MHC, then the NK cell won't kill. However, if for some reason that MHC class I is downregulated, be it because of tumor involvement or because of virus involvement that causes a downregulation of MHC class I, well, then the KIR is no longer seeing that MHC class I, and it's no longer sending that dominant negative signal. Now the only signal that's coming through is the positive signal through that pattern recognition molecule, and the cell will be destroyed. The NK cell will be activated, and it will kill that cell much in the same way that a CTL will kill. The release of cytotoxic granules into the environment, which will then punch holes into the virally infected cell. Now, I mentioned ADCC being a way in which B cells can be involved in the killing. And here's the process by which that works. ADCC stands for antibody-dependent cell-mediated cytotoxicity. So we have here a bacteria, for example, or a virally infected cell, for example, that's surrounded or coated in this surface antigen. These antibodies are specific for that antigen. So the antibodies with their antigen binding site, remember the paratope, will bind to those specific antigens, and that leaves the FC portion out in the environment free to interact. Well, the granulocytic cells all have FC receptors on them, and the FC receptors are looking for FC portions of the antibodies. So when they find these FC portions of the antibodies, that signals the granulocytes to degranulate. So NK cells, neutrophils, eosinophils, macrophages, they will degranulate. They can release lytic enzymes, they can release perforin, they can release TNF, all of which are cytotoxic to that cell that has the antigen on the cell surface. So that's why it's antibody dependent, because the antibodies are binding to the cell, to the target cell, but it's cell mediated because these cells that are actually destroying are not B cells and they're not antibodies, but these granulocytes, through stimulation of the FC receptors, will degranulate and destroy the target cell. Hence, antibody-dependent, cell-mediated cytotoxicity. Another cell to mention, a minor subset of T cells, are called gamma delta T cells. And these are kind of the black sheep of the T cell family. They're not adaptive, they don't have memory, they don't work like typical T cells. Less than 5% of all T cells are gamma delta T cells. They recognize non-peptide antigens as opposed to the peptides that the alpha beta or the regular T cells will recognize. These gamma delta T cells are located in skin and mucosa, and they secrete pro-inflammatory cytokines when they're stimulated. So in that aspect, they work kind of like an innate cell. These are T cells, but they're involved in innate immunity because, again, they don't have memory capacity. They're not specific for a given antigen, and they respond the same every time. They will get stimulated through these non-peptide antigen recognition receptors, and they'll secrete pro-inflammatory cytokines. So that's gamma delta T cells. So just a few pearls, things to remember, things to make sure you know walking into the boards if you don't remember anything else. As far as antigen receptor goes, remember when we talked about B cells, immunoglobulins made up of 2 heavy chains and 2 light chains. The heavy chain on the antibody is the VDJ recombination, and that dictates the isotype. Remember that each isotype has certain properties that are important and that distinguish it. IgM, for example, is a pentamer in serum, does not cross the placenta. IgA is a dimer in secretions, where it is usually found out in the mucosa. Remember that in antibodies, the light chains have VJ recombinations, and it's in either a kappa light chain or a lambda light chain. The TCR, similarly made up of a heterodimer, an alpha chain, and a beta chain. The beta chain has a VDJ recombination like a heavy chain on the immunoglobulin. The alpha chain has a VJ recombination like the light chain on the immunoglobulin. As far as MHC goes, remember MHC class 1 associates with that beta 2 microglobulin for structural purposes, presents intracellular or endogenous antigens from the cytosol to CD8 or cytotoxic T cells. MHC class 2 presents processed extracellular or exogenous antigen on APCs only to T helper cells. As far as the cellular response goes, some more pearls here. Remember that we have these naive Th0 cells or pre-CTLs that will circulate until they encounter antigen. The Th0 cells are activated by APCs with processed extracellular antigen, again MHC class 2, and the cytokine milieu in which this activation occurs will dictate the swing to either Th1 or Th2, depending on the cytokines that are present. Th1 are pro-inflammatory helpers. They activate CTLs, they activate NK cells, they activate macrophages. Th2 are pro-humoral helpers. They activate B cells. CTLs, or CD8 T cells, are activated by engaging nucleated cells that are presenting cytosolic antigen on MHC class 1. And remember, their whole effector function is to kill cells through certain cytolytic enzymes that are involved in degranulation. Gamma delta T cells and NK cells are also cytotoxic. They have primitive receptors. They may recognize MHC expression level, as is the case with NK cells. This concludes our discussion on effector functions of adaptive immunity. In the next section, we will discuss vaccine immunology.